Hello everybody and welcome to another Ask WHO Live. Today we're going to be discussing monkeypox. It's something that you're hearing about in the news, you're seeing on social media, and you have questions for us, so that's why we're here to answer your questions. So today we have with us three experts. I'm not one of them. My name is Nika Alexander. I work with the communications team here at WHO. The experts we have with us today are Andy Seal. He's an advisor with the HIV, Hepatitis and STIs program. Welcome, Andy. Thanks for being with us. We also have Dr. Rosamund Lewis. She is head of the Smallpox Secretariat in WHO's Emergencies program. And we also have a very familiar face, Dr. Maria van Kerkhove. You know her from being the technical lead on COVID. She's actually the lead for a program that looks at many diseases, coronavirus diseases, orthopox, which Hi everybody and welcome back. If you heard our introduction the first time around, we had some technical problems there. So I'm going to start off the top for any of you who is joining us new. So this is an Ask WHO Live, a social media session that WHO does to answer your questions. We've been getting a lot of questions around monkeypox. You're seeing coverage of it in the news, you're seeing coverage of it on social media. We want to help explain what it is and clear up any misconceptions. So, my name is Nika Alexander. I'm with the communications team here at WHO. We're meeting today in the Palais, the UN headquarters in Geneva, because we're at the beginning of the World Health Assembly. Joining us to speak about monkeypox are three people. First, we have Andy Seal. He's an advisor with HIV, Hepatitis and STIs program. Thanks for being with us, Andy. Next, we have Dr. Rosamund Lewis. She's the head of the Smallpox Secretariat in the WHO Emergencies program. Welcome. And we also have Dr. Maria van Kerkhove, who you've seen a lot speaking about COVID, but she leads a program that works on many emerging diseases and zoonoses. Those are diseases that come to humans from the animal world. And she's speaking with us because monkeypox is part of the diseases that her team covers. Nice to see you again.
Thanks for having me.
All right. So let's start off the top, and I think I'll go to you first, Dr. Lewis. Just very simply, why are we here? Why are we concerned about monkeypox? Monkeypox is not a new disease. Why are we talking about it all of a sudden?
Yeah, Nika, you're absolutely right about that. Monkeypox is not a new disease. It's been described for at least 40 years, and it's been well studied in the African region. We've seen a few cases in Europe over the last 5 years, just in travelers, but this is the first time we're seeing cases across many countries at the same time in people who have not traveled to the endemic regions in Africa.
Right off the top as well. We're equally concerned about the people in Africa who've been there are some countries in which it's endemic, meaning it happens more often, and people there have been experiencing the disease, falling sick from the disease for many years as well. So WHO has also worked with our colleagues in Africa to follow the outbreaks there. So it's almost two at the same time. We're talking about exported cases that we're seeing in countries where we don't normally see it, and also concerned about the ongoing outbreaks in Africa. Can you just tell us a little bit about the work we're doing, perhaps specifically in Nigeria?
Yes, Nika, that's absolutely right. We do have ongoing working relationships with the ministries of health and the laboratories in the African region. We have several countries that we work with very closely because they have been reporting monkeypox over the last few years. These include Nigeria, the Democratic Republic of the Congo, Central African Republic, and Cameroon. This is where we're seeing cases being reported now, and so we're working very closely with these countries to help respond and to help try and ascertain why this virus is now becoming more frequently reported, because it is well known to be, as you said, a zoonotic disease. So it is primarily in the animal kingdom, in forested areas. Now we're seeing it more in urban areas, and this week we're seeing it for the first time around the world.
Not completely around the world, but in several countries.
Yeah.
So that actually answers the first question we got, or the first question I got from our colleagues who are scrolling through the social media feeds for your questions. That was from Susan Therese Grimes, who was asking why the alarm now when there have been previous outbreaks. So I hope that answered your question, Susan. For everyone else, if you have a question to ask us, if you're on Twitter, use hashtag AskWHO. You've used that before if you've asked us questions on these lives. Otherwise, if you're on Facebook, LinkedIn, or YouTube, put your question in the comments, and our colleagues in the social media team are scanning through for those questions, and they'll send them to me on my phone. So I'm not being rude when I look at the phone. I'm actually looking for your questions. Let me see if there's anything else. People do want to know how it spreads. We're still in a COVID pandemic. We've very much got COVID on the brain. We have understood, I think, over time how not to get COVID. And I'll stay with you for this one, Dr. Lewis. How does monkeypox spread, and therefore how do you prevent getting monkeypox?
So let's just say right off the top that monkeypox and COVID are not the same disease. It's caused by a different virus and it spreads in a different manner. The way it does spread is through close physical contact. People who have monkeypox do develop a rash, and that rash, if you touch it, that can be contagious. So it is person-to-person close contact spread when it's within families or within social networks where close contact happens.
With us Andy Seal, and you might be wondering, why do you have somebody from the HIV, hepatitis and STIs program to speak with us as well? Some of the cases we have seen this time have been among people who identify themselves as men who have sex with men. We're still trying to understand the dynamics of the transmission, but for now there's some very specific advice we want to give with a community of people who are most affected at this time. So Andy, I want to hand it over to you. It actually would be interesting if you could mention the consultation you just had, and as well as what advice we have.
Thanks so much. So I think one of the things we've recognized with this outbreak, it's not typical. We're seeing cases, as you say, among men who identify as gay, bisexual, or from other groups of men who have sex with men in several countries, often linked to travel, or recent travel. And it seems clear, as Rosamund was saying, that this is linked to close contact. So this could be through social contact, possibly through sexual contact, which of course is close contact. We're still in the early days of this outbreak, so there's a lot we're still learning. But the communities themselves are clearly, number one, concerned and really keen on getting accurate information to help them understand risk and how they can manage the risk. And number two, they're really keen to make sure that information is proportionate and fair, and there's a lot of stigma and discrimination that surrounds many diseases. And I think the key thing we need to look out for is, as WHO, to work with our partners in communities and elsewhere to make sure that the messaging is correct. So while, for example, we're seeing, some cases amongst men who have sex with men, this is not a gay disease, as some people in social media have attempted to label it. That's just not the case. Anybody can contract monkeypox through close contact. We know as well in WHO that when we want to be responsive to an emergency or to an outbreak, in addition to really working with the experts, tracking the epidemiology, we need to work with communities really from the beginning. And so today we convened an initial meeting of members from the affected communities from all WHO regions, including some representatives from Nigeria, so from endemic settings as well as outbreak settings. And it was a fascinating and timely conversation. We had really sound advice shared, which it can be equally as helpful to us in managing and leading in the response as the science and the data. So we need to really bring the community perspectives together with the science. It's early days. We've got goodwill from the communities. They want to work with us and understand how best this can be contained.
Just to understand, Andy, you talked about that it could be spread through sexual contact, but it's not a sexually transmitted disease. Can you just clarify that for us? Because I think it almost sounds like the same thing. If you say sexual contact, it almost sounds like the same thing to somebody who's casually listening. So what's the distinction between a sexually transmitted disease and a disease that could be spread through sexual contact?
I think that's a great question. I think many diseases can be spread through sexual contact. You can get a cough or a cold through sexual contact, but it doesn't mean that it's a sexually transmitted disease. Typically, you need an exchange of vaginal or fluids or semen that has an element of contagion to it to transmit the disease. And my colleagues who are more expert in the science will probably explain that much more eloquently. But at the end of the day, I think the difference is that sexually transmitted infection is caused by by sexual intercourse, anal intercourse, vaginal intercourse, or oral sex, and you don't need to have sexual contact in order to transmit monkeypox. Close personal contact is sufficient.
Because as Rosamond was saying off the top, it's the rash and the lesions that can spread from touching one person to the other, because we can have tiny breaks in our skin that we're not even aware of, in a way. Maria, I wanted to come to you for sort of an overarching question. We said anybody can get monkeypox, but not everyone is at risk of monkeypox. Can you help us contextualize that? Who's at risk, who isn't at risk, based on what we know now?
That's a great question, and thanks for including me in the panel today, because we do want to make sure we put correct and accurate information that's out there. So this is an evolving situation, and so what we are learning from countries that have not typically had cases before, these are cases which are having outbreaks now. Cases are being identified in certain communities now, focusing on the surveillance in communities of men having sex with men. But as surveillance expands, we expect that we will see more cases. And I don't know contextually wise if we've actually said yet so far like what we are actually seeing, because it's very different than COVID, where we see hundreds of thousands.
I'm hearing that the audio is not very clear, so if you can just nip closer to your microphone, maybe just lean in a little bit.
Yes.
Thanks, Maria.
Is that
we want
better?
to make sure you get all her answers clearly heard. Yes.
Okay, let's try that again.
Hopefully.
So your question was to contextualize this and see where we are. So let me start with the context first, and then I'll go into the specifics of the question. So as Rosamond described, and as you've described, Nika, we're seeing not typical patterns of monkeypox transmission. And as Rosamond has said, we've been aware of this virus for 40 years. So in countries where we are seeing new cases that have not experienced cases before, surveillance has really focused on particular populations so far. And right now we are describing what we are seeing. And what we are seeing are cases being detected in the communities of men having sex with men, who identify as having sex with men. But as surveillance expands, we expect that more cases will be seen. But we do need to put this into context because it's not COVID. So we have so far seen, and I don't actually have the exact numbers at hand because we're learning more even as we sit here, but we're talking about less than about 200 cases of confirmed and suspected cases so far. So that may change over time. So this is really important why we have surveillance and why we have raised an alert to say, okay, we need to be on the lookout for this in countries that don't typically experience monkeypox. So we've been working with countries, we've been working with ministries of health to expand surveillance, to look for people who have rash, so dermatology clinics, emergency departments, infectious disease clinics, sexual health clinics, so that we really understand the extent of infection. But your question was, who's at risk? So as Rosamond has explained, transmission is really happening from close physical contact, skin to skin contact. So it's quite different than COVID in that sense. So we are looking for people who have rash, so we can help them first and foremost to understand what their risk is. And we should say that most of the people who have been identified so far have had more mild disease, or let's say not severe disease. But anyone they come in contact with needs to be informed so that we can prevent onward spread. And the thing I just want to say here is that this is a containable situation, particularly in the countries like where we are seeing these outbreaks that are happening across Europe, in North America as well. But we can't take our eye off the ball of what's happening in Africa as well, in endemic countries. So this gives us an opportunity to talk about what monkeypox is, what it isn't, so you can be very well informed. Can you hear?
Thank you.
Yeah?
Can we hear, guys? Are we able?
Yeah.
Are we okay? Audio's okay. We're getting the nod from our technical folk over there, so that's good. I just want to summarize the symptoms. We've mentioned rash, but it would be rash with blisters on the face, hands, feet, eyes, mouth, and/or genitals. Fever, swollen lymph nodes, headaches, muscle aches, and low energy. So just because you have a rash, unless you are the contact of someone, you're close contact of someone, or you're within a community where there really is monkeypox, follow up with your healthcare professional to find out what it is. But not every rash is going to be monkeypox. I think that's the whole idea, is that there's some people who need to be extra careful right now and other groups of people not as much. There is a question about whether or not the World Health Assembly, which is when all the ministers of health come together and meet to discuss WHO's work, whether they would be declaring monkeypox a health emergency. It doesn't quite work that way. Actually, the Director General of WHO convenes something called the Emergency Committee. Then they meet and discuss whether or not this situation constitutes a public health emergency, and then they advise the Director General whether or not this should be declared a global health emergency. So that's answering Maria Ailman, who had that question. That was on Facebook. Yeah, please.
I just want to comment on that because as the World Health Organization, we bring expert groups together all the time. You know, we're talking about these pathogens like monkeypox, like COVID, chikungunya, Zika, and that's a common thing that we do. We have expert networks that we work with all over the world. I talk about this all the time for COVID, but we do this for other diseases as well. And that's not unusual for us. We have technical advisory groups, we have our strategic advisory groups for infectious hazards, and we bring them together to brief them. And we also ask for their advice on what WHO should be doing. And this is what the Director General, has all the time. We bring this together. Whether or not we will have an emergency committee or not is also something that is discussed across many of the different pathogens. Monkeypox would be no different. And I think I just want to get some misnomer out there. This is part of the process of WHO, and these are the mechanisms that we have. So it's always in the background. It's always a consideration. But what we're trying to do in working with Rosamund, so Rosamund you'll hear a lot more of on monkeypox because she is our focal point on this and she's the expert. But I just wanted to be clear that we do these types of things all the time, and it's good for us as an organization because we are lucky to be able to bring together the world's expertise across so many different topics of clinical management, of IPC, and monkeypox will be no different on lab. And it's great to work with Andy and the team on this because there's just a lot to learn. Yeah.
Those of us who've worked in emergencies for a few years, this is exactly the kind of thing where you get that gut feeling. Our technical colleagues say, this is unusual, and then you just do what you do. You convene the group of experts. From the communication side, we've been working with our colleagues in the regions to make sure everybody has the information at their fingertips. If there's questions we're not answering, we're putting together that information, as Maria says, across the technical networks as well. So we're working away on it and sharing information with you as much as we can as it comes in. There was a question on, just a second here. There's a question on whether or not there's something about the virus itself that has changed. Why are we seeing this happening now? What are your thoughts on that, Dr. Lewis?
The question is about whether the virus is changing. So we don't have the answer to this. We don't really know. We can say that this is a DNA virus. It's one of the largest, if not the largest, amongst the largest viruses known. The mutation rate is much lower than for RNA viruses, and so it's a very stable virus. So we don't yet have evidence that there's mutation in the virus itself. So we are beginning to collect that information, as you've said. We will be convening our groups of virologists and other experts who will discuss this very question based on the sequence of the genome of some of the cases that are being detected as we speak now. So we're beginning to start seeing these genome sequences being made available, and then experts will be able to look at that and tell us more. But right now we don't have the answer to that question other than what we already know about orthopox viruses, which they tend not to mutate and they tend to be fairly stable.
And note that she said tend, and this is what we know, and we're following up. I mean, as you've learned through following the science of the COVID outbreak, pandemic really closely, you've seen that we have what we know now. More research is done, more information is shared with experts, then we learn something more and we will share with you what our understanding is as it moves along. And I say we, I mean as the global health community, not just as WHO. We have a question on Facebook from Wakar Ahmad, who's asking, what is the progression of the skin lesions? I think that's another Dr. Lewis question. So how does it start? What does it look like initially? And how does it evolve?
So you described earlier some of the typical early symptoms, which tend to be fever, headache, lethargy, backache. And this usually lasts for a day or two. We call it the prodromal period. That resembles many other things, of course, in the early days, first day or two. Then a rash begins, and the rash is has traditionally in the past been very classical for monkeypox, which is it starts with what we call macules. These are just red areas. Then it progresses to papules, and papules is something you can feel, it's raised. Then it progresses to vesicles, for which the regular term would be blisters, which is why it can be confused with chickenpox, for example. Chickenpox also appears as blisters on the skin. Then it progresses to pustules, so these little blisters can begin to fill with a whitish fluid that looks like pus, and so they are called pustules. After that, they begin to dry and scab, and after that, the scab falls off. That is the classic progression of the rash. In terms of the body itself, the classic progression is face and then to limbs, palms of the hands, soles of the feet, and then to the body itself. That also is a classically described progression. Another classic picture from monkeypox from past years is the swollen lymph nodes. You might recall that the World Health Organization and all countries of the world eradicated smallpox, and the eradication of smallpox was declared in 1980. And so that disease no longer exists, to show that some things are containable even when they've been around for a very long time. The reason I raise this now is that at the time of eradication of smallpox, monkeypox had already been identified in people. 1970 was the first time. So we had a period of about 10 years when we had a little bit of both. And the distinction between smallpox and monkeypox was the swollen lymph nodes. If child had swollen lymph nodes, it was more likely to be monkeypox than smallpox. So these are some of the things we know already, because countries that are familiar with this infection, this infection that comes from the animals in the forest actually, they are familiar with this, and so this is what has been classically described for a long time. What we are seeing today, still we have that picture, but we also have a higher proportion of cases where the rash may begin a bit more locally and it may remain a bit more locally. Possibly because of the nature of the contact, again we don't know, but we're seeing more cases where the rash begins in the genital area, which is not new, that has always been there, but it's more frequent now, and sometimes it tends to stay there. So it's also possible that the rash may not be visible because it may be covered. If it doesn't reach your hands or your face, then it may not be seen. However, it does remain important to consult your healthcare provider, because that rash can even contaminate your bed sheets, your clothes, and so on. And so you don't want to expose people in your family, for example, or your other social contacts to contaminated materials, which is also one way in which monkeypox can spread.
Brings us on to another question. I think it fits in well again. So we've been saying right off the top that not everybody's at equal risk, and in communities where there are people, in social networks where there are people with monkeypox, those who are most at risk are their close friends, their close contacts, their family members as well. Historically, you mostly saw monkeypox would spread between family members and also sometimes health workers who are helping those people. So here's a question from Vasiliki Angoridi, and this will be for you, Andy. Saying, can you please elaborate more on the MSM comment, because many officials have considered that a rushed superficial approach that only fuels discrimination. So just talk a little bit again, maybe even just again, why you're with us and why we're having, for now, an inclusive approach, focusing in part on men who have sex with men, but as Dr. Van Kerkhove explained earlier as well, we're also asking countries to look in dermatology clinics, primary health care, and elsewhere to see if they can find further cases of monkeypox. So that was a very big preamble, but just wanted to pass back to you, Andy. Can you explain why you're here and why we have special concern and working especially with communities of MSM?
Of course. So yesterday we issued some interim public health guidance for gay, bisexual and other MSM, and it really tried to answer the question you just posed to me, essentially. And really one of the things that we've, again, it's early days and we don't have all of the information yet, but this demographic is generally a demographic that really does take care of health screening when it comes to potential STIs. So for example, we know that MSM, if they do spot an unusual rash, they're likely to want to get it sorted out quite quickly. So they'll want to go and seek health advice. They'll want to access an STI clinic if they have services in their local area. And so the fact that they've been proactive about responding to unusual symptoms might be part of the story. And again, more of this will really become clearer in the weeks and days to come. So I do think that could definitely be part of the story. Similarly, I think the classic thing here is that, we have this atypical outbreak. It has been widely reported in the mainstream media in a number of countries. Sometimes the reporting is very good. Sometimes it does come, sadly, with some misinformation, stigma and discrimination, not only about the MSM community, but perhaps also unintentionally suggesting that this is an African disease by only using images of black skin, for example. And so there are ways that we can work with communities to learn from really decades of experience around tackling stigma and discrimination with HIV. We want to apply those lessons learned to this experience. And again, we work very closely with colleagues on COVID as well around the same issues. How can we make sure that communities are helping inform messaging, helping us with the surveillance around myths and misinformation, collectively directing people to trusted sources of information, and really encouraging people to act appropriately, responsibly, and really do their very best to find trusted sources of information and advice.
Can I come in on that one? So in addition to what you've described here, I think we need to, when we respond to something that looks different, it looks new for whatever reason, as public health professionals doing an outbreak investigation, we need to describe what we see, right? We describe what we're learning. It's not to say that we know everything. It's not to say that we know what's going to happen tomorrow. But today we need to describe what we're seeing, and where we saw the first cases are one of the indications as to why this perhaps is a different situation from what we've seen before with monkeypox. So it's not about discrimination. It's not about stigma. It's about saying, where are you seeing the first cases? How can that help you do contact tracing? How can that help you with the investigation to go and find out perhaps a different type of source to begin with? But where is it spreading now, and how is it spreading now? These are questions we ask ourselves in the middle of an outbreak investigation.
I know colleagues have said that repeatedly. We're basically describing what we know now, and we share more information as we get it. So a couple of administrative things. I said this in the first intro and didn't say it in our second intro. Why are we not wearing masks? We're a little bit closer together than you've been used to seeing, for example, Dr. Van Kerkhove and Dr. Mike Ryan in their Facebook Lives. We're in an open space. We always say try to be in open spaces as much as you can. There's more air circulation here, so that's good. We have our masks. We're just not wearing them now. We would wear them if we were in closer proximity. We've all been vaccinated, and as part of this health assembly, everybody is meant to do a COVID test every morning and only come in if their tests are negative. So we've all done that as well. Another administrative thing, I know a lot of our journalist colleagues are watching us here, but these Ask WHO Lives are for the general public. Please write to us on the email address that you know so well with your questions. The box is being monitored as it always is, and we'll get back to you that way. And we've seen you have a couple of questions for us, but we generally aren't answering media questions through this platform. This is really for the public. And Dr. Van Kerkhove, I want to go to you next. What is WHO doing about this? We've touched on a few things, but can you give us the overview of what WHO does, not just in a situation like this, but in this situation?
I can, and then I'm going to ask Rosamond to supplement because there's quite a lot of activities that are ongoing. I mean, one of the things we really need to do right now, I mean, we're working with partners. We'll always work with partners and scientists and technical colleagues all over the world, but we have some major areas of focus that we are working on right now, and we are working with member states to achieve these things. One is we have to raise awareness about what monkeypox is, what it isn't, and we have to expand surveillance. So particularly in countries that aren't used to seeing monkeypox, we need to equip ministries and governments and countries, health clinics, to be able to recognize what monkeypox is and to ensure that people who may be suspected as having monkeypox get the appropriate clinical care. We want to stop human-to-human transmission. We can do this in the non-endemic countries, and this is really critical because we're in a situation where we can use public health tools of early identification, isolation of cases, supported isolation of cases, talking with communities, listening to communities, engaging with communities to be part of the solution. This is not about WHO telling the world what to do. It's about working with communities to say, how do we come up with solutions that fit in this. But I do want to reiterate that this is a containable situation and we can stop human-to-human transmission. We also want to protect frontline workers. Anyone that's out there that's taking samples to do testing or to care for individuals, we want to make sure that they have the right information, they have the right personal protective equipment, and we want to utilize all of the countermeasures that are in place. There are some antivirals, there are vaccines, but we have to utilize these most appropriately for those who are most at risk in an equitable fashion. And again, lastly, overarching is to advance our understanding about what monkeypox is. So we're going to be having a big global meeting around R&D, research from everything from the epidemiology all the way through diagnostics, therapeutics, and vaccines, and that'll be happening next week. But Rosamond can supplement that because there's so much other activities that are actually happening there.
I think you've covered a lot of it, Maria. One addition that we could offer is that, as you say, we work with experts around the world on a regular basis. You've mentioned it as well, Andy. And so what they help us do is draft the guidance. So we have materials online. Some of you may have already looked at the training materials that are already on the OpenWHO platform. There is an introductory course there. There's also an intermediate course there that really takes you through quite an extended course of 2.5 to 3 hours, and if you set aside a little time and you want to do that, you can learn a lot about monkeypox. Anybody can do it, it's free. You'd register on OpenWHO platform, but it's free and anybody can do it. I would like to mention that course was prepared over the last couple of years, and it was released in January of this year, right before this event has now become apparent in May of 2022. So you'll see that the information was really targeted towards health workers in the Democratic Republic of the Congo, in Nigeria, Central African Republic, and Cameroon. This was our target audience for that training. So don't be surprised if you see that the voices, the sounds, the images, the pictures are designed for our target audience. Now we're very happy that you're going to be looking at these, but don't think that we just made up this course yesterday, because it really has taken some effort, and we're going to continue to make that effort to provide information. In order to do that, we will also draft guidelines for health authorities around the world. So guidelines on surveillance and contact tracing and isolation, guidance on laboratory, guidance on communications. This target audience is different. This target audience is for the ministries of health of our member states, and so it will go at a different level. They will also be available online, and you will also be able to look at them. But for every product that the WHO produces, there is a different audience, isn't there, Nika? And so this is what we try to do. We try to tailor the messages and the audiences, the products and the materials for you. And it's a tremendous privilege to be here today with you, the public, and to answer your questions. And we do the same for different audiences, including our member states' ministries of health.
I think that's another example of the ongoing work WHO had already, but I've heard you say this already, Dr. Van Kerkhove, in previous settings. There hasn't been enough work on monkeypox. There aren't widely available vaccines, there aren't widely available therapeutics, and yet there are people who experience this painful, unpleasant and in some cases deadly disease, and more needs to be done. And perhaps this is an opportunity, now that the world's eyes are focused on this, that some of those things can happen. I have a question from @aura03113 asking, is it true that the smallpox vaccination can protect against monkeypox as well? And even if that vaccine was received a long time ago. So we know some information related to that. I'm not 100% sure, but I think that's back to you, Dr. Lewis.
Right. So, of course, there was smallpox vaccines available, and those contributed tremendously to the eradication of smallpox. At that time, it was learned that, it was observed and studies were done, that the smallpox vaccines used at that time were protective against monkeypox about 85% of the time. If you've been following, of course you have been following vaccine efficacy information around COVID and other diseases, you'll know that 85% is not perfect, but it's also not terrible. And I would also add that this is a vaccine effectiveness that is attributed to the older vaccines, and we now have new vaccines, because although smallpox was eradicated, this research has continued for the last 40 years, and people were wondering why. Well, this might be a good example of why, that these viruses are closely related to each other, and now we have the benefit of all those years of research in diagnostics, in treatments, and in vaccines that will be brought to bear upon the situation now. However, because these are relatively newly discovered products, they are not yet widely available. They are available to some ministries of health in national stockpiles, but they're not yet widely available commercially. So another area of work that we'll be engaging in will be to work with the partners and the commercial and sector and industry to see what we can do now to enhance availability of these products.
Because I think we have a real opportunity here. You know, as Rosamond has described, there are products that are available, but they're not widely available yet. And we have an opportunity here to use these appropriately and to use these for those who are at risk. So we will be making recommendations on who, should be prioritized for this. This is not something that everybody needs. It is a virus that is spreading between people who are coming in close contact with those who are cases. And we really need to discuss, evidence-based use of these measures, access, and equity. We really, as a global community, have another opportunity to do this right. And so what we want to make sure, and we are going to be working really hard across all of our partners, whether it's from manufacturing or whether it's from our ministries of health and whether it's the general public, to make sure you understand what the risk is. And we will be doing these regularly, and inform you about what the risk is. And if the situation changes, we of course will issue information through all of our channels to member states and to the public. But we have a real opportunity here, and I couldn't let that go. Just given the situation that we've had with COVID-19, there are some parallels in terms of access, and this is really important.
Communities are already saying to us, if we get this right, if we contain this, if we get the access right for the outbreak, we have to do this for the endemic countries as well. And I think this is where the opportunity is coming in, and the communities have already spotted this, they're already talking about it, and it's something that I think is definitely part of our intended approach.
Thank you. And with that, we're going to wrap up. We haven't answered all your questions, but we do see and hear your questions, and we fold the answers into our speeches, into our Q&A, into the products we put out on social media platforms. So continue to ask those questions. That helps us know what you need to know. If we're not communicating something clearly, we help by seeing if your questions show that confusion as well. So do keep giving us your questions through #AskWHO. I want to thank our experts for being with us today. We had, at the end of the table, we had Andy Seal, who's with the WHO program on hepatitis, HIV, and STIs, that's sexually transmitted infections. Thank you very much. Somebody noted there was actually a neat comment from somebody saying that you were totally right. It's because MSM are extremely good at checking themselves that we have part of this signal. So thank you for being with us, Andy. We have also Dr. Rosamond Lewis, who's the head of the Smallpox Secretariat in WHO's Emergencies Program, and I think maybe you understand a little bit more about how smallpox and monkeypox are related now. And lastly, we have the most familiar face of all, Dr. Maria van Kerkhove from the Emerging Diseases and Zoonoses program, within also the Emergencies Program. Thank you all very much. See you next time.